Welcome, nurses. I'm Mario, and today we're tackling high-alert medications, drugs with a higher risk of causing harm if used incorrectly. Medication safety is the foundation of patient trust. One mistake can have serious consequences, but with the right knowledge, we can prevent errors. We'll cover insulin, heparin, chemotherapy, and more, plus practical strategies for safe administration. Let's sharpen your skills and keep our patients safe. Let's get started. Insulin is essential for diabetic patients, but it's also one of the most high-risk medications due to its narrow therapeutic index. With many types and look-alike vials, mix-ups are common and can be dangerous. That's why the independent double check is the gold standard. 2 nurses must agree before giving insulin. This teamwork is a critical safety net and it should never be skipped. Heparin is a powerful anticoagulant used to prevent and treat blood clots. Its dosing is complex and errors can be life-threatening. Too little risks clots, too much causes bleeding. Independent double checks and strict protocols are essential for safe heparin administration. Always verify every number and monitor closely for bleeding. Let's talk about an electrolyte that demands our utmost respect, potassium chloride or KCl. We use it to correct hypokalemia, but it is one of the most lethal drugs we can administer if given incorrectly. The primary danger lies in rapid intravenous infusion. Pushing concentrated potassium directly into a vein can cause immediate cardiac arrest by disrupting the heart's electrical conduction. This is why you will see bold black box warnings on concentrated KCl vials, stating must be diluted and fatal if given undiluted. It should never ever be available as floor stock in its concentrated form. It should always be dispensed from the pharmacy in a pre-mixed diluted IV bag. The safety rules for potassium chloride are absolute. First, always verify that the concentration is appropriate for the route of administration. Peripheral lines have strict limits on the concentration and rate of infusion to prevent phlebitis and pain, while central lines can accommodate higher concentrations. Second, always use an infusion pump. Never ever administer potassium via gravity drip, as it's impossible to guarantee a precise controlled rate. And third, labeling is paramount. The IV bag must be clearly labeled with the total amount of potassium, the base solution, and the intended infusion rate. It's our job to be the final gatekeeper, ensuring every single safeguard is in place before that infusion starts. Morphine and fentanyl are powerful opioids for pain, but carry serious risk, especially respiratory depression. Fentanyl is 50 to 100 times more potent than morphine, making dosing errors dangerous. Always monitor patients closely and keep naloxone available as your safety net. Administering chemotherapy agents is a specialized skill that carries significant risks for both the patient and the nurse. These drugs are cytotoxic. They are designed to kill rapidly dividing cancer cells, but they can't distinguish between cancer cells and healthy cells like those in our bone marrow or our skin. For the patient, this means a high risk of severe side effects. For us, the healthcare providers, these agents are hazardous. Exposure through skin contact, inhalation, or accidental ingestion can have serious long-term health consequences. This is why handling chemotherapy requires a level of precaution far beyond standard medication administration. The first rule of chemotherapy is personal protective equipment, or PPE. This isn't just a pair of gloves. It means wearing a chemotherapy-tested gown, double gloving with specific types of gloves, and wearing eye and face protection. All preparation should be done in a biological safety cabinet to prevent aerosolization. When it comes to administration, the principle of independent double-checking is non-negotiable and often involves 2 chemotherapy-certified nurses. They verify the patient's identity, the drug, the dose calculation, often based on body surface area, the route, and the rate. We also have to be experts in managing extravasation, the leakage of the drug into surrounding tissue, which can cause severe tissue damage. This is a high-stakes, high-skill area of nursing. Beyond heparin, we have a whole class of anticoagulants like warfarin and enoxaparin that require our careful management. Warfarin, an oral anticoagulant, is notorious for its delayed onset of action and its numerous interactions with other drugs and even foods, particularly those high in vitamin K. The therapeutic window is incredibly narrow, and keeping a patient's international normalized ratio, or INR, within that specific range is a constant balancing act. Enoxaparin, a low molecular weight heparin, comes in pre-filled syringes, which seems simple, but different strengths and doses for prophylaxis versus treatment can lead to confusion and errors. Preventing errors with these medications hinges on meticulous monitoring and patient education. For warfarin, this means ensuring regular INR checks and communicating any dose adjustments clearly to the patient. Patient education is huge. They need to understand the importance of consistent vitamin K intake, the signs of bleeding to watch for, and the need to inform all their healthcare providers they are on warfarin. For enoxaparin, it's about ensuring the correct dose is chosen for the correct indication and that we're using proper subcutaneous injection technique to prevent hematomas. Double-checking the dose, especially when transitioning a patient from one anticoagulant to another, is a critical step to prevent bleeding or clotting complications. Neuromuscular blocking agents, or NMBAs, like vecuronium or rocuronium, are some of the most dangerous medications we handle. Their purpose is to induce muscle paralysis, which is necessary for procedures like intubation and surgery. However, they do not provide any sedation or analgesia. A patient receiving an NMBA is completely paralyzed but can still be fully awake, aware, and able to feel pain if not adequately sedated. The biggest risk is respiratory arrest. These drugs paralyze all skeletal muscles, including the diaphragm, meaning the patient cannot breathe on their own. Administering an NMBA to a patient who is not intubated and mechanically ventilated is a catastrophic and almost always fatal error. Because of this profound risk, the protocols surrounding NMBAs are incredibly strict. First and foremost, a patient must have a secure airway and be on mechanical ventilation before an NMBA is even considered for continuous infusion. Sedation and analgesia must be administered first and assessed continuously. To prevent accidental administration, NMBAs should be stored separately from other medications and be labeled with prominent fluorescent warnings like "Warning paralyzing agent." When a patient is on a continuous NMBA infusion, they require intensive monitoring, including train-of-4 nerve stimulation to assess the degree of blockade, in addition to continuous cardiac and hemodynamic monitoring. There is absolutely no room for error with these drugs. Concentrated electrolytes like potassium chloride, magnesium sulfate, and hypertonic saline are high-alert medications. Their concentrated forms can be dangerous if not diluted and administered carefully. Always use pharmacy-prepared, pre-mixed bags and never store vials in patient care areas. Monitor patients closely for adverse effects and signs of toxicity. Adrenergic agonists like epinephrine and norepinephrine are powerful vasopressors that we use in critical situations like cardiac arrest, anaphylactic shock, and severe sepsis. To support blood pressure and cardiac output, these are definitely life-saving drugs, but they're incredibly potent and have a very short half-life, meaning their effects are immediate and can diminish quickly. The primary risk here is dosing errors. Because they're so potent, even a small miscalculation in the titration of an infusion can cause extreme hypertension, which could lead to a stroke, or cause severe vasoconstriction, leading to tissue necrosis and loss of digits or limbs. Safe use of these drugs requires constant vigilant monitoring and really precise administration. These medications are almost exclusively given as continuous IV infusions via a smart pump, which has built-in dose error reduction software. The nurse must carefully program the pump and ideally have a second nurse independently verify the setup. The patient requires continuous monitoring of their blood pressure, often through an arterial line for real-time accurate readings, as well as continuous ECG monitoring. You are constantly titrating the dose up or down based on the physician's parameters to achieve the target blood pressure. It's a dynamic and hands-on process that demands your full attention to prevent severe cardiovascular complications. Total parenteral nutrition, or TPN, is intravenous nutrition for patients who can't eat. It's a lifeline, but also high risk, requiring meticulous sterile technique and double checks to prevent infection and metabolic complications. 2 nurses must verify the TPN bag and patient identity before starting. We monitor blood glucose closely and always taper TPN to prevent complications. A GEPA2S. In today's hospitals, the closed-loop medication system is changing how we deliver medications. But what exactly is it? Slight pause. The closed-loop medication system is a fully electronic process that links prescribing, dispensing, and administering medications, all in real time. Here's how it works. A doctor enters a medication order into the electronic health record. That order goes directly to the pharmacy where the medication is prepared and barcoded. At the bedside, nurses like me scan both the patient's ID band and the medication barcode before giving any drug. If everything matches, the system gives the green light. If not, it alerts us to double-check. This system reduces human error, helps prevent adverse drug events, and gives us peace of mind that the right patient is getting the right medication at the right time. For patients, it means safer care and more confidence in their treatment. For nurses, it streamlines workflow and adds an extra layer of safety, but no system is perfect. Closed-loop systems can't replace our judgment. Technical glitches, barcode errors, or workarounds can still create risks. That's why we stay alert and never skip safety steps, even with the best technology. The closed-loop system is a powerful tool, but it's our vigilance that truly keeps patients safe. Every safe choice you make protects your patients. Double-checking doses, speaking up, and teaching patients, these actions form a shield of safety. You are the final, most important safety check between medication and patient. Your vigilance and dedication save lives every day. Thank you for being a healthcare hero.